Hello, everyone. So next in the investigation series, I wanted to talk about biometry and lens selection. We spoke about sort of corneal imaging, and I mentioned that I would be going through some biometry. And I'll probably also put this video in the cataract playlist as well, just to sort of have it there as a reference for those going through the sort of the cataract videos. So. We're going to talk about just sort of how to interpret biometry, which I find is something when you're starting off, it's all just a bunch of numbers, and trying to find some context to them is always helpful when you're wanting to understand what your boss is kind of deciding between and what sort of lenses are being chosen. And why. So that's what we're going to sort of go through today, the approach that I take to biometry and the approach that I think most people take, and then the sort of things that I want you to think about or that are worth thinking about when you're approaching your lens choices. So we'll use the IOLMaster. I think it's the thing that most people will have come across when they're looking at a biometry. We'll go through a normal case, the usual patient coming through your door, waiting for cataract surgery, how to choose a lens, and then lastly, we'll just touch on things of what to watch out for. And I'll be mentioning those throughout the presentation anyway, but I'll give a bit of a specific run through of them near the end. So with the IOLMaster, you've either got the sort of 500 or the 700, but essentially it's actually a very, very accurate machine, and it's replaced what we used to use in terms of things like the A scan, for example. The only limitation with the IOLMaster is that it's quite limited in very dense cataracts, but with the IOL, with the 700, for example, you're usually able to get a reading in around 99% of patients. So it really is the very, very dense cataracts that you're not going to be able to get an IOLMaster reading from. And it doesn't require any contact lens. There's no contact on the eye. But the thing that I wanted to mention here is that you're wanting to remind your patients that if they are contact lens users, they need to make sure that those contact lenses have been removed for a specific amount of time before they have the biometry. So usually for soft lenses, it depends on where you work. The guidance will range anywhere from between about 2 days up to about 2 weeks. And with hard lenses, again, 4 to 8 weeks is the usual guidance of not wearing those lenses before the biometry so that you're not getting the wrong result. And it's really very easy to perform. You can just follow the instructions on the machine, and usually you could just do it yourself. So this is what you're going to get in terms of your printout. You're going to get this, you're going to get this reading. You'll have lots of information, lots of numbers, and the idea is what do you actually do when you're going through this? So always start with the patient details. Check that you've got the right patient. Sometimes, depending on what electronic record you're using, sometimes these biometries can feed directly through into your electronic record. But if there's if there's a misprint with the number, those records can then end up on the wrong patient. And if you're looking at paper notes as well, again, very important to make sure that you're not looking at the wrong patient. Then I like to just check that the status is correct. So the patient should be phakic in the eye that you're about to operate on. And you also want to just double check the refractive target. So we can talk about that in a moment. But essentially, most of your patients will come with a refractive aim of 0. That will need to change if you're aiming for something like low myopia, for example. I then look at the axial length of the eye. The first thing that I always do is actually just look at the raw number and then also just compare it to the other eye. If there's a difference of above about half a millimeter, red flag should be kind of waving in just trying to make sure that difference in the axial length is accounted for. So is the patient's refraction very different, for example? Or if it's not, then it's always worth either repeating the IOL, and like I said, the IOLMaster is usually very accurate, or sometimes an A scan can be helpful as well, just to kind of cross-reference the numbers. And if they're sort of similar, then what you're looking at is a true difference in the axial length. But do bear that in mind, where if there's a difference of about half a millimeter or more, just take a step back and make sure that that difference is accounted for. So with your axial length, anything less than about 22 and anything above 26, that's just kind of, again, making you consider any additional risks in the surgery. And also, it kind of will change the formula that you're using. So it depends on where you work, what formulas are being used. But if you, for example, are used to using the SRKT, then if your eye is less than 22 millimeters, then you ought to be using the Hoffer Q. Whereas if you're using the Barrett Universal II, for example, then usually there's no difference, no matter what the axial length is. I also look at the anterior chamber depth. So again, planning the surgery, stratifying the risk of the patient, and those numbers should usually be between about 2.5 to 4 millimeters. And sorry, that should say anterior chamber depths. Anything that's too shallow, anything that's too deep poses risks for the actual cataract operation. Then I start looking at my K values. So I want you to consider what angle they're at, and I also want you to consider the delta K. So any delta Ks of about 1.5 to 2, depending on the boss that you're looking for, may trigger a sort of extra step that will be taken in the surgery, and then we could talk about those at a later date, of astigmatic correction. So that's either with, for example, limbal relaxing incisions, maybe sort of a corneal section on the opposite angle, things that are done intraoperatively to try and flatten your cornea with incisions. But a delta gave above 2, and again, this depends on where you work, what the protocol is. Sometimes it might be 1.7. If you're in the private sector, it may well be lower. But in the NHS, for example, here in the UK, any delta K of above 1.7 to 2, depending on where you work, usually triggers whether or not the patient should be assessed for a toric lens. And then if you are getting high delta Ks, it's always worth then having a tomography. This is, for example, showing you on the right-hand side a rough tomography, but usually something like a pentacam, and you can go back and watch the video on corneal imaging um, to actually check whether or not those astigmatisms are regular, and whether or not that patient is suitable for a toric lens. And then finally, you're essentially going to choose the lens that gives the refractive outcome that you've wanted and discussed with the patient. And we'll talk a bit about that in a bit as well. So when it comes to choosing a lens and counseling your patient, you want to think about the current refraction and the habits of the patient, the systemic and the ocular comorbidities, and also what the actual patient's choice is. And we'll go through those in detail. So when it comes to the current refraction and the habits of your patient, is what are they currently doing? How are they wearing glasses? How are they wearing their glasses? Are they wearing their glasses just for reading? Do they wear them for distance and for reading? Do they drive? Are they amblyopic in either eye? What is their dominance? And you can sort of look up a very easy test of checking whether or not they are right or left eye dominant. And what some surgeons I've worked with like to do is, for example, in the dominant eye, they would aim as close as possible to zero. And then in the less than dominant eye, they would aim for something like a minus third, for example. And that's usually to try and get a sort of almost a mini monovision. So is there a high anisometropia? And that's very relevant as well, because if the patient's refractions are very different, if they're above about two spherical equivalents between the two eyes, then and you're aiming for emetropia, you might want to warn the patient that actually this is somebody who may suffer with anisoconia and asymptomatic anisometropia between waiting for both eyes to be done if you're not doing them both at the same time. And is there a high cylinder on the refraction? Look at the biometry. Is there a high delta K? Look at their tomography. Is this a patient that will possibly need a toric lens? Then think of the systemic and the ocular comorbidities. Is the patient mobile? Are they bed bound? And when you're thinking about this and whether or not they could have further surgery, part of the reason I think about this is when it comes to deciding whether or not I want to put a lens in that I may, for whatever reason, although unlikely, have to change or replace. And that tends to be the case with your toric lenses. So if your toric lenses shifts, for example, for whatever reason, and it can't be corrected with them, or it's having to be corrected with quite astigmatic glasses, and the patient wants it to be redone, you may have to go back in the eye to either reposition the IOL or maybe even replace it entirely. So if this is a patient that you think is going to be difficult for them to even have their first operation, it may sometimes be worth just discussing with the patient, having a lens that goes in the eye that doesn't require any further surgery, and then just having an astigmatic correction with glasses. Have they had any other ocular surgery? Is this a patient who's had a corneal operation? Are they somebody who has a trab in place? Um, is this somebody who is probably not going to be able to handle a toric lens in the eye. For example, from corneal pathology, is it somebody who has a corneal scar? Is it somebody with keratoconus? Or is it somebody with, for example, like this OCT is showing, do they have advanced geographic atrophy? Is a toric lens going to only make their issue worse? Do they have an ERM? Any retinal pathology, corneal pathology can sometimes reduce the likelihood that you're going to be using a toric lens, because by putting an essentially an astigmatic lens in the eye, you can really change how the light is bending. And if that's not absolutely bang on right, and they have a problem with their retina, or they have a problem with their cornea, you can sometimes worsen their symptoms of things like glare. And then obviously, finally, the patient choice. What do they want to use their glasses for? So on the NHS, when you're offering only monofocal lenses, you ought to just remember that you're reminding the patient that they're going to need the glasses for something. And that's either going to be for reading, if they're going to aim for emetropia, or you may aim for low myopia, but they would need glasses for everything else. And you might be surprised as to what the patient actually wants. Some patients want to be glasses free for reading. And that's because most of their life is spent either doing, crosswords, or looking at their phone, or looking at their iPads, and they're not doing a lot of distance vision, and they're happy to just wear the glasses for when they leave the house very infrequently. But for those who are a bit more active, they may want to actually, like the vast majority of your patients will want to aim for emetropia, and then just are happy wearing glasses for reading. It's also important, if you're working somewhere where you're only offering monofocal lenses, just remember to take a step back and advise the patient that there are premium lenses available in the world, and they're more than free to go and explore those options if they want to. They may not be available on the NHS, but sometimes these patients only find out about them afterwards, and then you're left with a patient who's quite unhappy because they're telling you, if you had told me that these lenses were even possible, I may have actually gone and had this surgery privately, but now you've already done the surgery. And then you want to also counsel for the risks of toric lenses. So with toric lenses, remember that they have to sit in a specific axis. If they move, they can worsen the astigmatism. And usually the numbers that you're looking at is less than 5% of them end up, causing a problem from an astigmatic point of view. And about 5 to 10% of those are then having a secondary surgery, because usually the glasses are enough to sort of fix the astigmatism that's left in the eye. But that's just a reminder to the patient. And also, has this patient dilated well in your clinic? Is this somebody who's going to be tricky getting a toric lens in? And in terms of your refractive aims, most of your patients, like I said, will be aiming for emetropia. There is a small proportion of your patients, especially the already myopes, who have been used to being able to do everything at their in the short distance vision. With no glasses at all, and they may be used to that, and they may not want to change that. So do make sure you're having that you're counseling the patient for that. This matching the second eye, what you might find is in patients who have, for example, quite dense cataracts, but they're in the middle of, quite severe other ocular pathology. They're pathological myopes, for example. The other eye is about a -7 or a -8, and then this eye develops a traumatic cataract or a lens touch cataract, and you're simply just wanting to take the cataract out for purposes of getting light into the eye and being able to assess the fundus. What you may want to do is actually, for these patients, is just match the second eye. And this is why sometimes you might find, in the very, very odd case, the actual refractive aim is something like a -7 or a -6, because you're wanting to match the other eye, rather than actually aim for emetropia, because that high anisometropia won't be possible to deal with glasses. They would need contact lenses, and if they're not appropriate for contact lenses, then that might be a reason that you won't bring the eye back to zero. And then this whole, do we aim for zero? Do we aim for -1/3? It depends on who you work with. Some bosses I've worked with like to just aim for the closest negative number to zero, whatever lens that is, they'll go for it. Some prefer to just go for the -1/3. I have worked with some, like I said, where they will check the dominance of the patient, but usually right-handed patients are right eye dominant, and the opposite applies to the left-handed patients. But what they may prefer is, depending on the dominance, they would, in the dominant eye, aim for closest to zero, and in the non-dominant eye, aim for -1/3. And sometimes you don't have the luxury of doing that because of where the biometry lands. Your lowest minus number may be a -0.15, for example, so you're going to go for that regardless. So let's go through a bit of a case. So you've got a usual patient coming in, 67-year-old, gradual fogginess to the vision. They're normally fit and well, no other medical or ocular history, and they wear bifocals. Their refraction shows a low myopia in both eyes, and the biometry is as follows. And noted on the refraction as well, there's not a lot of difference between the two eyes, and they're using their bifocal glasses. So they have low myopia. They're currently using their glasses for both distance and reading. They are a driver. They're right eye dominant. They don't have an astigmatism. There's no amblyopia. There's no ocular history of note. They'd like to go for distance vision, and we've discussed with them the options of premium lenses, and they don't want to go for them. So when it comes to the actual patient's biometry, what we're going to do first is obviously we're going to check the patient's details. We can see that the patient is phakic in both eyes according to the machine, and we've aimed for a target refraction of 0. So the first thing I'm going to look at is the axial length. So what we can see here is it's 23.15 in that right eye, 23.19 in the left. There's not a lot of difference at all. It's less than half a millimeter, and our anterior chamber depths are 2.69 in both eyes. So that's all nice and normal, nothing alarming at the moment. Then we're looking at our delta Ks. So the delta K is only 0.48, nice and low, nothing to worry about from putting a spherical lens in. Our K1 is 42.35, K2 is 42.83, and that tells us that the steep axis K2 is at 114. Now, where this is relevant, it's probably less relevant now, but people used to use this, and sometimes people still do, in terms of choosing where to sit on the eye. Now, with the newer keratomes, with the newer types of surgery, where our keratomes are only 2.2, 2.4 millimeters, most people will tell you that a section that's only 2.2 millimeters wide is not really changing the K values of your cornea. But when those corneal sections used to be 3 or 4 millimeters, they definitely were. And that's where all of this is coming from. So if I take a quick reminder, if I look at this diagram now, just bear in mind that the actual angles on this eye, so the angles are correct, but please imagine that that eye that you're looking at is actually the right eye, not the left, even though you can see that caruncle on the on the left hand side. So this isn't a left eye, this is a right eye. And these angles are essentially where the angles are on the right hand side, and it's exactly the same on the left. So it's 180 to your left hand side down to 0 on the patient's nose on the right eye, and then again it starts at 180 and then round to 0. So usually if you're sitting temporally, your section is going to be roughly 180 to 190 degrees. If you're sitting superiorly, your section is going to be about 1 to 110. So on this patient, for example, where the steep axis is at 114, some surgeons may choose to sit superiorly if they're right-handed, because then it means their section is going to sit almost exactly where that steep axis is, working to flatten the axis slightly. Now, like I said, with a 2.2 keratome, with a 2.4 keratome, you're not really going to make much of a difference to those K values anyway. So this is probably not necessarily worth thinking about, but it's just a quick comment in terms of if you are hearing your bosses or people talking about where you'll sit or where this axis is, this is how it's calculated. So the 180 starts to your left-hand side, down to 0 to the nose, and then it starts at 180 again at the nose and all the way around to 0 again on the left eye. So that was just a quick comment on that. Then we come to our lens choice. So we've got the SRKT formula, which is the appropriate formula for the eye length at 23. A 24.5 lens gives us an aim of about minus 0.11. 25 gives us minus 0.46. So this patient is right-handed and right eye dominant. We're going to aim closer to 0. So we'll choose a 24.5 lens. So in the end, the patient wants to aim for emmetropia, and we've chosen a 24.5 monofocal spherical lens placed in the bag. So things to watch out for, and we've already spoken about this, but it's just to sort of finish on what you're kind of considering and remembering to consider when looking at these patients in terms of counseling them and what to consider when it comes to your lens choices. So anisometropia, like we said, a difference in the two eyes of less than about 2 is very manageable. The thing is that just remember though, if both of those eyes are roughly -4 and then you bring one eye to 0, there's now going to be a difference of 4 diopters, and that can be very difficult for the patient. So even though the patient wants to aim for emmetropia, and they may well still aim for emmetropia with the surgery, it's just warning the patient that what they may need is a contact lens in the interim if their second operation is delayed for whatever reason, or just as long as that they're aware that they may suffer from the anisometropia. Then obviously with irregular astigmatisms, just because you're seeing a high delta K doesn't mean that this patient is immediately going to get a toric lens. So remember to do your tomography, look at that astigmatism, see exactly how it's sitting on the cornea. Is that actually just there because the patient's had a previous pterygium surgery and actually their central cornea isn't astigmatic at all and they just need a spherical lens? So just remember your tomography is a very helpful tool in putting that delta K into context. Consider whether or not you can see any corneal or retinal pathology or anything that makes you think that a toric lens is only going to make the situation worse. So even if you are seeing an astigmatism, the patient may still benefit more from having a spherical lens placed. Then also consider the risk of your PCR and actually the stability of your bag. So even though, you're going to be aiming to put a lens in the bag all the time, but if this is somebody with really quite bad PXF, a very unstable bag, do you want to be putting a toric lens? Two reasons here. Is it going to be something that's going to be easy to rotate without causing unnecessary risk during the surgery? And then afterwards, if this is a patient that doesn't have much in the way of stability of the bag, even just a tiny bit of zonular dehiscence post-op, even just a tiny bit of a subluxed lens can really make a toric lens quite unbearable for a patient. Whereas an aspheric lens with a tiny bit of dislocation can actually sometimes be, quite manageable for the patient. Finally, like I said, so when you're looking at the biometry, just keep a keen eye on the axial lengths and check that if there is a difference, then there's a reason for it. So, for example, if you have a much shorter eye, but it also happens to be much more hyperopic, then, things like that are adding up. But if they're not adding up, and actually the shorter eye also seems to be the more myopic eye, just make sure, your biometry is repeated, look at your OCTs, and potentially even consider doing a B scan to look for a staphyloma that you may not have been aware of. But just generally, just make sure that there's something that's explaining that difference in axial length. So we've spoken about how to just approach your biometry, how to choose a lens for cataract surgery, and the main thing that I wanted you sort of to take away from this is A, just the approach to the normal patient, but also what to consider in your clinics when you're looking at the biometry and what should be raising alarm bells for you. There may not actually ever be, markers of anything wrong per se, but if there are the common errors that I spoke about in terms of, missing the aniso, missing the difference in your axial length, these are the things that are always worth having on your mind so that you can just check so that you're not finding yourself post-op in a situation that you'll otherwise regret. So I'm hoping you found this useful. Please remember to give out to fill out the feedback. The link is in the description. And thank you very much for joining and we'll see you at the next one.